It is Tuesday, September 14th, 2021. This is a work session of the Portland City Council.
Recording in progress.
And it's being recorded. This is a terrific opportunity for the Portland City Council to hear about some of the regional efforts that are underway, as well as local efforts that are underway to address mental health issues. And this is an opportunity for us best to understand what the services are that are being provided, where the gaps are, what sort of infrastructural needs there are. And ultimately, this is about how we as a city council can better work with and collaborate with our partners throughout the mental health delivery system. And so with that, I'll turn this over to Mike Myers to facilitate our conversation today. Good morning, Mike.
Good morning, Mayor. Excellent introduction. Thank you. And thanks, Mayor and Council, for having us today at this work session on our Regional Behavioral Health Network. My name is Mike Myers. I am your Community Safety Transition Director, and I'll be working with a number of speakers today. This is just one of several work sessions that you'll have with me over the next few days and months. This one over the Regional Behavioral Health Network. On Thursday afternoon, you'll be with me on a work session to discuss the Community Safety Transition Direction Division's work plan. CAO Tom Reinhart will be facilitating that work session with you. And then November 2nd, the goal is to have a gun violence reduction work session on that date. But today we'll be discussing our regional response to behavioral health. I'm joined, and thank you, and I'm joined today by Interim Director of Multnomah County's Behavioral Health Division, Julie Dodge, who will lead our discussion. Julie, thank you so much for all your work over the last month and help putting this work session together and your presence here today. We very much appreciate you. We will be also joined by representatives from Portland Project Respond, Portland Street Response, and the Portland Police Bureau's Emergency Crisis Intervention Team, and the Behavioral Health Crisis Emergency Network will be giving a presentation also. Here's why we're here. Mental Health America, and I'll put the organization's website in the chat so you can view it on your own. But Mental Health America ranks Oregon as 49 out of 51 in our ability to provide service to individuals experiencing mental health trauma. The city does, and I think we all agree, the city has a responsibility to provide emergency response services. The question is, where does our responsibility reside and how can we be the best partner? And then we must begin and continue to create these partnerships that facilitate and address the public health crisis from a regional perspective to ensure optimal use of our resources. That is the goal of why we're here today. Some goals of the work session today are: one, we're providing the City Council with a holistic understanding of our behavioral health response system as a region. We'll hear from city and regional programs on how they're addressing the behavioral health crisis. We will have the opportunity to discuss where gaps in behavioral health services exist and strategize on how to address gaps in regional services and resources. Where are those gaps in behavioral health infrastructure, and how do we ensure people have access to these services? And then we'll determine an approach to create sustainable infrastructure for people experiencing situational and chronic mental health trauma. So with that, Julie, I know you have the opportunity to share your screen if you want to go ahead and get that started. And I would like to kindly welcome Multnomah County's Interim Behavioral Health Director, Julie Dodge. Julie, thank you for being here today, and thank you for leading us in this discussion.
There we go. Good morning, and thank you, Mayor Wheeler and Commissioners. It's very much a privilege to be here with you. I'm Julie Dodge. I'm the Interim Director of Behavioral Health for Multnomah County. I use she, her pronouns. And as Mike mentioned, we have a collaborative presentation that talks about how the city and the county work together in our crisis services, but we're going to do a little tone setting as part of that. Also joining me on this portion is Jackie Thompson, who up here, it says she's the program manager for Project Respond, but as of this week, I believe she has a new title, and I'm going to mess it up, but she's now oversees all of the crisis services for Cascadia Behavioral Health. Robin Burek is also joining us as the program manager from the Fire Bureau's Portland Street Response. And Lieutenant Casey Hetman is joining us, I think, from Camp Rylea, so because they're also doing trainings today, but he'll be talking about the Portland Police Bureau's behavioral health responses. just a little bit of what we'll cover in this portion, and noting that as we move on towards the end, we'll transition over to Aaron Loans, and I believe Jill Archer from Care Oregon, and Nan Waller will be joining him as well, Judge Waller, to talk about the Behavioral Health Emergency Coordinating Network, which is part of this, what we see on your screen, the new opportunities in behavioral health. But, at the beginning, we want to do a little tone setting and talking about which crisis we're talking about, because, there are a lot of crises out there. And as Mike mentioned, yeah, we don't have good health, behavioral health access. Whether you're talking about mental health or you're talking about substance use, we don't score well. So we'll talk a little bit about what crisis we're going to focus on today. We'll address the continuum of care in terms of what is the full crisis network, as well as our specific response network, the first responders who go out in those emergent situations. And then we will lead to what are some of those new opportunities that are coming that we hope will improve some of the access issues that we're facing. So, what crisis are we talking about? I see that there are three kinds of crises that people talk about. One is a systemic issue. Not only do we have this historically underfunded system throughout the state, when we talk about that underfunding, it's not just about having competitive wages, but it's funding our organizations in a manner that allows them to provide the kind of supervision and support and training that allows workers to do what they do best. And that organizational support has to be anti-racist. It has to include policies and procedures and processes that honor the culture, value, experiences of the people we serve, as well as our employees. It also has to be trauma-informed. And when we say trauma-informed, a lot of times we think about serving just the people we're serving, but that also means recognizing the experiences of all of our workers who are doing this work, that they are daily dealing with people's emergencies and hearing stories that are traumatic, and they themselves need to be in spaces that are well supported and encouraged, and that their work schedules allow them that time for respite, for relief, for encouragement, support. And most of our organizations are not funded in a way that supports that either. We also, in this time of pandemic, you may have been hearing, and if you haven't, you will be hearing about the dramatic drop in workforce. At the end of August, the Mental Health and Addiction Certification Board did a survey of all 10,000 of their certified behavioral health workers. Within a week, they got about 3,000 responses to this survey. And what they found is that about a little more than 1 in 5 workers are not working at all in the field, or are only working part-time or on call because of primarily the stress. And they talked also about low compensation, not enough support, high levels of stress, and the kind of traumas that they're experiencing. What this means in Multnomah County and in the city of Portland, 40% of outpatient services are understaffed. Across statewide, we've seen a decrease in outpatient mental health and behavioral service access by 40%. We were already number 49 in the nation. And this isn't specific to Oregon, honestly. We're seeing the same level of exodus from the field across the country. So we might not actually be dropping in our ranking, given that everyone seems to be experiencing this. But we're also in our residential spaces, our mental health residential, we're down about 25% of our capacity because of staffing issues, because people aren't able to, organizations aren't able to hire and retain their staff. There's also been COVID restrictions. We had not had in any of our residential facilities throughout the county any positive COVID clients since January. And in August, we had 13 new cases. And when we have 13 cases, that means that's impacting all of the folks living in those residential facilities. Our alcohol drug residential facilities are also struggling. We're having challenges identifying or keeping the medical staff required in both mental health and behavioral health or substance use treatment facilities. So that's a crisis. Those are all systemic crises. they're the high level stuff, and things we're working on include there are multiple organizations who have submitted letters to the governor and legislators this past week. You'll also see an op-ed coming out in the Oregonian shortly. And we've also been meeting with the Oregon Health Authority weekly since the beginning of July to try and address some of these issues. We're working on it, but things don't happen quick enough. And what we really need is a cash infusion to support those organizations that are struggling not only to pay competitive wages, and many of them have increased their wages in spite of not having increased funding, but their organizations are struggling financially because with fewer clients and fewer, that means lower revenue. And some of them are just struggling to stay open. So we are asking the state for an immediate cash infusion to help those organizations, because frankly, most of our funding at the county comes from the state agreements. So yeah, there's a systemic crisis that is compounding all of this, and that makes it even more difficult when it gets to, so where do people go? We also have a public crisis. And what I mean by public is, yes, we have people living outside in some of those broader system spaces, but it is the average person on the street who sees someone having an emergency, or not even having an emergency, someone who is rummaging through their garbage or coming up on their property. And while that may present a public safety issue, it might not be a behavioral health emergency, even if that person has mental health concerns. A lot of the people that we see out and about on the streets are not necessarily in what we call an emergency, a crisis. And I'll get to that in a moment. But they do live with chronic mental health and substance use concerns. And why that's important is because unless someone is imminently a threat to themselves or to someone else, and by imminently, we mean that right now or in the next few hours, they intend to harm themselves or someone else, we cannot force someone to go into services. All of that comes into a lot of relationship building. But for the person who is seeing people outside in their neighborhood, downtown, or wherever, camps everywhere, the average citizen experiences that as troubling and as a crisis, and they want us to fix it. And I don't mean to minimize that, but there's a different navigation space for that. And finally, we have the individual. And that's really the focus of what we're talking about today, is when an individual is experiencing a mental health or substance use crisis, what happens then? When they are experiencing, imminent suicidal threats, when they are becoming violent and aggressive toward people around them, when they are breaking and damaging things because they are not able to manage their behaviors or they're not aware of their behaviors, that's when we're talking about an emergency or a crisis. So I want to kind of set that tone, because I hear all of these different levels of crisis talked about, thrown about when we talk about the behavioral health crisis. All of them are true, but today we're focusing on what do we do for the individual who is truly experiencing that crisis. So who's responsible for this? And that's why we're here, right? The city has a role and the county has a role. Multnomah County is identified by the Oregon statute, ORS 309, as the local mental health authority, which is given the responsibility to oversee and coordinate all behavioral health services within our designated area, which is in the entire county. So it's our responsibility to be working on that plan. Now, up until 2020, we were also the care coordinating organization, which gave us a lot more leverage and flexibility in funding. Now, Care Oregon handles that responsibility, and Trillium also has some responsibility in that space. So we partner with Care Oregon and Trillium to develop those plans and to make sure that we are working in alignment. But we retain statutory authority and responsibility for that coordination and oversight. And that includes, in particular, what we call the safety net, all of these crisis services that are part of our service, our continuum. The city has a responsibility for public safety and emergency response. And so that is everything from, when crime is occurring, to fire and rescue, to helping transport people to safe spaces when they've been, injured or are at risk. And that overlapping space that you see in this little diagram, that's where our crisis services intersect. And the key point here for me is that we absolutely at the county have full respect for the city's responsibility. And we work diligently to partner with our, mid-management and our ground level folks who are doing the work to make sure that at the service level, we are working in tandem and collaboration instead of in competition. And we know there's been breakdowns in that. And as part of some of the spaces that I have been interacting with, formerly with Chris Davis and now with others who are coming in, we talked about how can we build better relationships between, street level officers with street level behavioral health workers, so that they can be more and more comfortable with calling each other to say, hey, I need help in this circumstance, which is especially true when we're dealing with some of the chronic mental health and substance use issues, but also important in the emergency situations where people may be reluctant to call one another because of a lot of the stress that we've experienced, particularly associated with law enforcement. So we both have roles and responsibilities, and it's important for us to be coordinated. Kind of moving forward into the individual space, a behavioral health crisis is an emergency. For the person who is in the middle of that, they are often overwhelmed. They don't know what to do. It's like their nose is flat up against the wall and they can't see anything but that immediate space in front of them. And that may feel like a very hopeless space. Sometimes the person is very quiet, sullen, and withdrawn. Sometimes they are aggressive and violent. What it requires is an intentional, consistent, systemic response that brings all of the players together so that we can help facilitate as much as possible a smooth access to care. And does that always work? I'm not about to tell you it does. I think you all know that there are challenges, whether it comes to the impacts on workforce in lots of different spaces. We have challenges throughout. We've had, you may or may not have heard about the stresses at the Oregon State Hospital, which essentially means they're only accepting those folks who are mandated by the criminal justice system, what we call legal assist or aid and assist, to access that, which means that other people who are committed civilly are having a great difficulty getting access to the state hospital. It's a very small portion, and that means that those folks are staying in our psychiatric hospitals here in the region, which means that people who are having emergency are having a more difficult time accessing those spaces. That whole system is kind of jammed up. So just noting, those are some of the challenges that we're dealing with. That's at the systemic level, but we're still working with it. And so what are some of those things that we need to have? Well, we do have, I'm sorry, I put up my, the chat popped up in the middle of that. In terms of our full crisis system, there's a lot that is happening. And it's important for you to know about those things because, they don't always get talked about. Behavioral health isn't known for our marketing skills, and we never have been, but we have a full continuum of services that are in place, and it starts in the prevention space before someone needs emergency services. That includes wraparound services, crisis planning, housing and employment support, access to healthcare, and we have teams and spaces in all of that work with people who have ongoing mental health and substance use concerns to help keep them stable in the community. That includes programs like the ESA program, which is, I always forget the acronym, but basically it's a program that serves young adults and adolescents who are experiencing their first psychotic episodes. And they get up to 2 years of support and learning to develop skills, to manage their mental health crisis situations, to prevent crises, to access care, to gain employment, and to maintain in the community. They get intensive support throughout, as I said, up to 2 years. We have wraparound services, we have outreach teams. The early intervention space is where we talk about all the hotlines. And most of our hotlines, they include the Multnomah County Call Center, but also all the lines operated by Lines for Life. And folks can call them at any time to talk through different circumstances that they're dealing with. The Multnomah County Call Center, which I'll talk about more, specifically has access to information for people who are already connected to behavioral health services. We have family and community support partnerships, including peer-led organizations like NAMI, the Mental Health Association of Oregon, outpatient services, outreach services, including our new PATH team, which is promoting access to help, which is funded in part through the Joint Office of Homeless Services, as well as the County General Fund to do outreach and support for people who are houseless and are at risk of legal involvement, who have substance use concerns. And the idea is to build relationship with them, help them access the resources they need, starting with harm reduction and hopefully helping them access alcohol drug treatment as they're willing to go. The blue little part of your cycle here is the response. This is the emergency space, and that's where the bulk of what we'll be talking about today is, and that includes crisis stabilization, our mobile crisis teams, our urgent walk-in clinic, as well as emergency services, including psychiatric emergency services that people typically gain access through, primarily through Unity, but also can go through Providence and Emmanuel and other spaces. After response, we have the aftercare, the post-vention, which is including treatment and supports, peer support services, and care coordination. We also have a Multnomah County intensive treatment team that works with people who are exiting secure residential facilities to help them develop a stable pathway as they're entering into the community. So that's the full continuum. Then we get to where our work as a city and the county overlap, and that is what happens when someone calls with an emergency. And this little diagram, I know it's not perfect, but it's intended. You see the person on the phone saying, all right, I'm going to call somebody. And typically they call either 911 or the Multnomah County Call Center. Those folks on those lines will triage the situation, listen to the story, find out what's going on, and figure out, do we need to provide them referrals and resources, or do we need to activate mobile crisis? 911 can deploy Portland Street Response, Project Respond, or Portland Police Bureau. Typically for Project Respond, they'll connect to the call center, which will activate Project Respond, but 911 can do that directly as well. They also can refer a person to respite care or family crisis, or to CATSI, which is what we call a subacute space. It's a temporary space, 14 days stabilization for folks who are having psychiatric emergencies. Or they can make recommendations to access the urgent walk-in clinic if someone is able to maintain but is feeling distressed, or connect, particularly the call center can connect you with their provider or other community-based resources. In terms of the call center, the Multnomah County Call Center, I know you all hopefully are pretty familiar with what 911 and BOAC do, but the call center, you might not be as familiar with the level and volume that we handle. We receive about 70,000 calls per year. And that includes a full range of things, from people who are having actual emergencies to needing better access to their providers, coordinating care, access to other services. We're open 24/7. We have staff available 24/7. And in the pandemic, we've been able to sustain that, even though people are no longer in one space in the call center. They are doing that, remotely. And they are a service and support access point. They conduct risk and suicide assessments, and we are able to deploy first responders, including law enforcement, through connecting with 911 and or Project Respond. They can also connect folks to outreach teams and the full range of things that you see listed in this circle. So a lot of those things that you saw in the earlier diagram, the call center can help people access the appropriate space. All right.
May I ask a question here?
Sure, Commissioner, go ahead.
If we can go back to the previous slide on the Multnomah County Call Center.
You bet.
Just so everyone knows, I'm the commissioner in charge of 911. So we share a lot in common with the Multnomah County Call Center. Can you clarify for me and the public when folks should call the Multnomah County Call Center as opposed to 911 or non-emergency?
Really, they can call anytime that they have any concern at all related to behavioral health, whether it is mental health, substance use. They can call if they're seeing a crisis. They can call if they see someone outside who needs support. We can activate, just as BOAT can, a welfare check. We can walk a person through what are those opportunities. I mean, some people feel comfortable engaging with someone outside. Some people don't at all. We can talk them through the circumstance and help them find what is the best support. And we've got the time available to do that. So it's not a rush call. We'll stay with someone on the call. We also do follow-up calls with people to make sure that they're able to access the care and support that they need. Does that help, Commissioner?
Yeah, it sure does. What are the hours of operation for the Multnomah County Call Center?
24/7.
Okay, great. Thank you.
Mayor
And I
Wheeler,
should have put up here, the number is 988-4888. Mayor Wheeler, you're muted, but go ahead.
It's Commissioner Hardesty's job, not yours. She's usually the one who reminds me because it happens like 5 times a meeting. First of all, thank you, and I'm loving this presentation, and I'm so appreciative of you and others being here today to share this information. One area that I keep getting asked about is how people know about and remember all these different numbers and who to call and where to call. And I had an idea, and it's something I know that is already done on places that are high frequency suicide locations, which is, it says if you need help or somebody to talk to, please call this number. But it occurs to me, just given the prevalence of mental health issues in our society today, they are ubiquitous, that maybe just some smaller signs posted in obvious places around town might help people to realize, oh yeah, I remember I saw that sign over on that sign pole or on that utility box or whatever. Maybe there's a way we can do more together just to sort of let people know that there are places they can call and what the number is, and maybe a prominent one or two in each neighborhood, just so people get used to the idea that there is a place that people can go and numbers that they can call, or they can remember, oh yeah, I saw that sign 4 blocks away. I'm gonna go down and see what the number was on it, kind of thing. It just seems like now that our society is finally beginning the process of acknowledging mental health as a severe health issue, that Portland can really help the community and the county set a good example of how to really highlight it for people so they can gain access. It's just a thought. Thank you.
That's a great suggestion. And Commissioner Ryan.
Yes. Hi, Julie. Thank you so much. This is a great presentation. While we're here, and I didn't realize there were 70,000 calls a year that went to your group. I wonder how many go to 911 per year while we're on this topic?
I don't have the specific number. I know that when we talk about some of the project respond calls, let me just actually pull up the numbers.
I'm sure someone from the city can answer that. I'm just curious how many calls go to 911 per year.
Yeah, I don't know off.
1 million a year.
Yeah. Yeah. Basically, we get about 1 million calls.
Okay.
Yeah.
I thought it was helpful to have that contrast, right?
Sure. Actually, we have Director Causey here. Do you want to give us a 30-second overview of our call volume?
Yeah, thank you. I'm Bob Causey, Director of BOEC for the record. And I've also invited Melanie Payne, our training manager, and she is our point person for behavioral health calls. So Melanie, if you have that information quickly, otherwise we may have to go do some digging and provide that.
Thank you so much, Bob. I think, Commissioner Ryan, were you just looking at our overall call volume, or were you interested in knowing how many calls are related to mental health?
I think overall would be fine at this moment.
Yeah. So the number that I heard earlier, I think we took 1.1 million calls last year,
Okay.
if not more. So just to give some context.
Yeah.
1.1 million that were related to behavioral health?
No, 1.1 million overall.
Total. Okay.
Yeah, actually, can I jump in? Do we actually know how many mental health calls we get on 911 or non-emergency? Is that easy? Or someone have that off the top of your head?
It is not easy to ascertain. It would take a lot of figuring. We don't classify calls as mental health.
Okay, thank you.
You're welcome.
So in interest of giving you a chance to hear about those other things and how they coordinate the actual mobile crisis on the ground, I'm going to move us along. We have basically a coordinated mobile crisis response, and that continuum starts with Portland Street Response, which we are, love the city's innovation and also the collaboration that went into developing the street response. The research that went into the design of Portland Street Response involved a lot of you, including Commissioner Hardesty, Ebony Clark, who is my boss now. Some of those recommendations were that it should be separate from police, no lights and sirens, that it should focus on what can we do in that moment to listen, to de-escalate, and to help people begin to, build relationships to begin access those services that will help them in their long run. We were to avoid uniforms, do a lot of education around what is an emergency versus what is chronic. And I think Portland Street Response is an essential part of our continuum because they really do. I think their good space is in that chronic person who has ongoing mental health and substance use concerns, and how can we best support them? And I will frankly say that, the more we can expand our access to other services from not just mental health and addiction treatment, but housing, employment, and other healthcare services, the more successful they will be. But they're intended to be non-emergency, serve those folks who are living outside, who do not have weapons, are not actively engaged in the moment in criminal activities, and are not currently violent. In the middle, the next step is Project Respond. Project Respond has been around, most people don't know, since the early 90s, and then formally with the funded through the county since the early 2000s. They were one of the first mobile crisis teams in the country. And they respond to those mental health emergencies where someone is imminently at risk of harm for themselves or someone else. They may be living inside or outside. It may be a call from a family member. They may be calling themselves. They may or may not have weapons, and they may not be currently violent. And then you have the Portland Police Bureau, which responds to those highest risk ones where there is violence, weapons, and or transportation might be needed. And I'll let those folks talk more about how they interact. There's an arrow between them because they do some co-response, but they will speak to that in more detail during their presentations. Commissioner Hardesty.
I will wait for the detailed presentation. Thank you.
Sounds good. And Commissioner Mapps?
Yeah, it would be helpful to me if we could have just a clearer explanation of the differences between Portland Street Response and Project Respond, and why it looks, and where there are differences, why they're different.
Well, I mean,
and like, why is one with the county and why is one with the city? Why do the services that they offer are kind of different, given or are they different?
Well, I think that's a valid question. I mean, the mobile crisis is part of the requirement for the mental health, our mental health services, part of our crisis continuum. So the county funds mobile crisis in the community using our state funds that we get. We also get some supports, some additional funding through what they call off the top funds from Health Share as part of the CCO agreement to help support mobile crisis. But that's really, intended for those people who are experiencing behavioral health emergency, who are imminently at risk for suicide or other harm or are otherwise unstable, where they need those additional supports. They are also authorized to do what we call a director's custody hold, which means that they can place someone, take someone into a facility because they are at imminent risk. And so in those times, it's the one time that we can step in and help someone get somewhere, even if they are not voluntarily wanting to do that. That requires, statutory training as well as oversight. Portland Street Response was not intended to deal with that population. They were intended to deal more with the chronic homeless substance use space, even though there are emergencies that occur in that space. And so that's why the coordination across all three is so important. And hopefully we'll get to more clarification as we move into the next, as they explain further their work.
So Julie, before we leave this slide, I just want to be clear that my colleagues understand. So Portland Street Response is a standalone operation. Project Respond, my understanding is only responds after the police have said it's okay for them to respond.
No, they go out before police. They go out, we can send them out from the call center. Sometimes they coordinate with police if there's been, if the caller has indicated that there is violence or at risk at the time. Police can also call Project Respond to come, but no, most of the calls are not originated by law enforcement.
So that's a different understanding for me. So I look forward to the presentation because I thought they could go without the police okaying it.
Nope.
Right.
They do things all the time. Dan or Commissioner Ryan, sorry.
It's fine. I respond to that. I have a question. Just from listening in, I've noticed that I know Portland Fire and Rescue also receives calls in the first responder system to behavioral health crises, and they're not listed here. Is there a reason why they're not listed on this? Not to say that we want more calls to go there. I'm just curious. The current reality is they're a part of that. Isn't that correct?
They are. We haven't had as much direct communication with them, and we work with AMR, but not as much with fire prior to Portland Street Response. Right now, I think Portland Street, as we all know, Portland Street Response is part of the Fire Bureau. And so right now they are that entry point, but we can definitely work on improvements on that. And I'll welcome any kind of conversation that would help that.
Yeah, I mean, we're just adding Portland Street Response and the system's changing, but I assume at BOAC, there's the tendency is to still send some of those calls to Portland Fire and Rescue. So I just wanted to, for the record, say that currently they are a part of this system, it seems.
Certainly.
I'm not trying to create a new system here. I'm just
but it is an excellent point for continuing to improve our relationships and coordination.
Yeah, thanks.
So I'm going to move us on. Robin Burrick is now going to talk more about Portland Street Response specifically, and then we'll have Jackie Thompson talking about Project Respond, and then we'll hear from the police bureau. So with that, Robin, I'm going to turn it to you and let me know when you want next slides.
Thank you so much, Julie. So Robin Burrick, I'm the program manager for Portland Street Response. My gender pronouns are she, her, hers. Lots of questions today around Project Respond and Portland Street Response. And I just want to clarify, so we are on the emergency, the first responder side of things. And so a lot of focus oftentimes is on police and the calls that we can take away from police, but we're also conveniently embedded within fire. And we have to think about the behavioral health calls that come within fire and look at this at a broader scope from public health as well, which is one of the unique advantages that we have being a program within fire. Julie, will you please flip to the next call? So all of our calls come from BOIC, which is our 911, our non-emergency line. We've gone on approximately 400 calls in about 6 months. 46% of those calls have come directly through 911. 42% have come through the non-emergency line, and 13% have been self-dispatched. So self-dispatch could be anything where we're driving around and we see a situation and we just pull over and check on an individual. We also get several self-dispatches just by listening to the radio and being embedded within the first responder system. We see what's coming in through police and fire, and we can actually put ourselves on that call. So just yesterday, for instance, we put ourselves on a call that Station 11 had been dispatched to for an overdose. And we got there first and were able to administer Narcan and save a man's life. So that's an example of how being embedded within the first responder system can be advantageous for us. Next slide, please. It's just some of the trends I wanted to note for you all. So we are currently responding to calls that are just outside. Eventually, we will move into taking calls that are in residential. But what that does is it really impacts who we end up serving. So about 60 to 70% of the individuals that we end up responding to are houseless. Most of the calls, though, that we're going on are somebody being called on. They're not necessarily calling for themselves. And so that impacts also our approach when we're going out to meet with individuals, because they're not expecting to see us. Additionally, what's really interesting is to note how many people we go on that are repeatedly called on. So what this points to is back to what Julie was talking about, those chronic conditions that individuals are facing. And what we're finding too with individuals that we end up meeting with often are that there's some of the most complex cases. So they have some systemic, chronic, long-time concerns, whether that's mental health, it could be substance use intoxication, or it could just be lack of basic needs. But also coming from the fire lens with the public health, we also are tracking chronic and acute health needs that come along with it. So it's very complex cases. Often some of the more vulnerable cases are the individuals that we end up working with. We also see an advantage to being able to get called on to the same individual multiple times, because to Julie's point, it allows us to build relationship with individuals, and they come to know us and they come to trust us. And this is really important. It's part of our trauma-informed care that we bring to this first response. The last thing that we've noticed the trend is that we see a large intersection between poverty and a lack of access to basic needs and services that intersect with mental health and substance use intoxication. And so the way that our model is built is that we dispatch our firefighter paramedic paired with a licensed clinical social worker. They get dispatched directly from 911. And then when we arrive, if we see there's an opportunity to refer somebody and get them connected to referrals and resources, this is a really major component of what the services are that we can offer and bring to the first response, sort of reinventing what first response looks like for the city. And this has been really critical when we talk about poverty and the lack of access to basic needs, because so often we find that individuals are not working with case managers. They're not connected to the system. And if they were connected to a system, they usually get disconnected because either they're moving around and it's difficult for that caseworker to follow where they're located, or there could be turnover in the industry. And so caseworkers will be switching jobs and it will be difficult to provide continuity of care. So one of the things that we offer with our community health workers is the ability to work with somebody as long as they need. And on average, we're working with someone anywhere between 30 to 60, maybe even sometimes 90 days at a time to make sure that we meet all of their needs. Next slide, Julie.
Just a second, I believe Commissioner Maps has his hand up.
Oh, sure.
Hi, Robin. Thanks for the presentation. I have a question about the services that we provide. It sounds like we both provide some stabilization services to our clients, and we also provide, we connect them to other services, which I assume are offered by the county or nonprofits. Mm-hmm. Can you tell me a little bit more about the network of services that we're connecting them to? How do those kind of working relationships happen? Is there enough capacity out in the county to intake and absorb the folks that we're sending them their way? Is there a system for thinking about that, or does each PSR employee kind of figure it out? on the basis of his or her own kind of personal connections?
Yeah, we've actually created an encyclopedia of resources for our staff so that as we bring new teams on, we have some continuity and consistency throughout. We have developed some really great partnerships, which I'll cover some of those on my last slide to talk about who it is that we find most helpful that we're working with out in the community. But we also have the ability. So Heather, for instance, she's able to do VISPA-DATS, which allows us to get people into housing, like submit housing applications and get people in that system. She also has the ability to sign people up for OHP, which is another certification. So as we bring people on, those are the types of certifications that our team will hold so that we have some connections within the systems as well. The other thing that we're doing is that we're tracking who are we making referrals to the most? How long does it take for us to get somebody into those referrals? And then if a referral or resource is denied for whatever reason, we are tracking why that resource was, what the barrier was for that, so that we can understand the system a little bit better and then communicate with our partners as well, so that we can navigate the system together better.
And I'll let you get on with your show, but I would very much like to hear what those barriers are. If there's something at a policy level, either at the city or county, that we can do to eliminate those barriers, I think that would be important work for us to engage in.
Sure, certainly. Thank you. So on this slide, I just wanted to talk about how mental health and substance use can intersect with other different call types that have come into 911. So when we ask the question, what's the difference with maybe the calls that PSR is taking versus Project Respond, really think about it from what are the calls that are coming into the 911 system that would traditionally go to police or fire. And so these are a few of those call types, right? Substance use intoxication, welfare checks, trespassing. That's actually one of the ones that we go on probably the most. Suspicious person, disturbances, unwanted person. And then from the fire side, we've actually started going on illegal burns because those are usually individuals that are experiencing houselessness. And illegal burns can often be from cooking or warming fires. So it's an opportunity for our team, including our community health workers, to go out and try to get people connected to resources there. And then fire also has had a type code called behavioral. And so those would be the intersection of mental health calls that intersect with medical type needs that would normally go to fire. And so we have seen ourselves get implemented and tied into each of these types of calls. And so there's an interesting intersection when we talk about we don't go on calls where there's criminal activity. That's really gray. So trespassing, disturbance, suspicious person, all of those have some sort of criminal element to it, which is why they're coming into the 911 system versus maybe Multnomah County crisis line, right? Okay, next slide, please. So what's working, what's not working? I actually built this slide with my community health workers. I sat down with them and asked them specifically what they would put here. And this is their feedback. They really, truly feel like we have done a great job at building trust in the community, particularly with those experiencing houselessness. And that has been in large partnership with Street Roots, who has the Street Roots ambassadors who have gone out and laid a lot of great groundwork for us. Trying to let people know who we are, that if we come around, they can trust us. But also it's our passion to be able to go and make sure that when we are responding to someone, we're responding with a trauma-informed lens, which means we are working to make sure that person feels safe when they're interacting with us and that they have the ability for choice as much as possible. Second thing, we're able to coordinate donated supplies very well through the Joint Office of Homeless Services. So in all of our vehicles, we carry around snacks and drinks and clothes. We have hygiene kits, we have all kinds of things, and all of that is through the Joint Office of Homeless Services. We have a huge, huge closet. If you've been to our facility, you've probably seen a huge closet of all these donated supplies that we have on hand, and we're super grateful for that. And then just some of the partnerships that we've formed that have been really successful for us. TPI has helped us significantly gather IDs for individuals. Old Town Clinic has provided a lot of medical care that we've been able to get people connected to. And then Rose CDC and Reach have both helped us significantly get people housed. We've had 6 people in 6 months that we've been able to get off the street and into housing, which maybe sounds small, but it's actually a lot of these individuals have been chronically homeless for many, many years. And so these are really big wins for us. and for the individuals. What's not working so well, so the subsidized housing, navigating the system is very labor intensive. It's not automatic. There's not an app that you can go to and just see what's available and where you are on the list. You have to do a lot of research and spend a lot of time just to get through it. And there's an extensive wait list for somebody to get plugged into housing. One of the other things that our community health workers noted was that we need more mobile showers throughout the community. There's just not enough. Also, there's a lack of tech access that creates a barrier to completing housing applications. So for a lot of our individuals who are applying for housing, a lot of the agencies will require that that person actually be the person to fill it out online. Well, if you're experiencing homelessness, that's difficult to have access to technology. And a lot of these programs will not allow somebody to enter an application on their behalf. It has to be that individual. So we're working with there is a nonprofit that provides technology through a grant for individuals with houselessness or in transitional housing. And so we're working with them to get people connected to technology and get their own computer as well as their own iPhones or smartphones. There's not enough low barrier housing. So one of the really big struggles that we see with a lot of individuals that we work with is that they've been kicked out of a number of places. They have a difficult time meeting the rules, and there may have some behavioral issues or substance use, which bars them from being able to access housing, and that's really difficult. So the people that oftentimes need it the most are not even eligible to be able to get into those systems. And then lastly, what we noticed is that leaving behind your belongings to get to appointments and to services provokes a lot of fear and anxiety because they're afraid something is going to get stolen. And so thinking about how do we tailor services so that we come to them rather than always expecting them to come to us. Portland Street Medicine does a great job, but thinking about even from mental health, how do mental health providers maybe create mobile outreach so that we're coming to individuals out in the street rather than expecting them to come into a traditional four-wall brick and mortar situation. So those are some of the things that we've seen. I believe that's my last slide. So if there's any questions, I'm happy to take any.
Mr. Hardesty, is your hand up? Okay. Thank you, Robin. And actually, I think what I should do here is direct a comment to Mike Myers. Mike, you're helping us think about how to make our public safety system work better. When I look at the problems on the right side of the screen, for the most part, these issues look like city issues. I can't point to my colleagues at the county and say, you're lacking here, housing, mobile showers, maybe even storing stuff seems like basic services that fundamentally the city either does provide or could provide. If you agree, I would love to see a set of recommendations on reforms that we can make in order to better support the work done by Portland Street Response.
Commissioner, I think we'll have room for having some conversation at the very end. We'll let Julie kind of get back to her presentation, but I will say this. My goal here today was to make sure that we're building strong partnerships with Multnomah County and identifying where those gaps are. You've recognized a few that are certainly related to the city, and Julie and I have talked. There are many that are related to the county as well, and we really do need to formalize what those gaps are and attack them in a partnership. And so, Commissioner, I will do that. I will outline what those gaps are that I think the city has responsibility, and I know Julie and I talked about outlining where we can help support the county. And I want to be bullish on this. This is a crisis. That's what I think we can all agree. This is a crisis, and we need solutions. And it's not going to be, these aren't easy solutions, or we've had done them already. So I'll be pushing on those issues, Commissioner. You can expect that, and I'll take good notes and circle back with you and the team toward the end here.
Thank you,
Commissioner Ryan.
Yes, hi. Robin, it's so good to see you, and thanks again for hosting me for a morning about 2 or 3 weeks ago. If you go back to the last slide, please. I don't know who's in charge of the slides. Clearly I'm not. Okay, there it is. When I looked at what's not working, you had it for a second, there it is. What's not working, when we were there, I think what I was taken with was that the proportion of calls that you're getting through 911 aren't what we wish they were. And it's okay. It's again, we're building a new system. By inserting Portland Street Response, the other parts of the system have to adapt and change. And so I was geeking out with you on your whiteboard, scribbled up there. I'm sure you recall, and you had to erase it after I left, or hopefully I did. But anyway, my point is, I think that what's not working right now, and at the beginning stages, which makes sense, because it'll improve, is the percentage of calls that you receive would increase from the 911, because at the moment, that's 46% of where you get your leads. And their habit is to give those calls to police or to fire. And that's because it's a habit, because you're new. And so my point is, I was surprised that it wasn't up there on what's not working. And I just wanted to add that to the bullet list there. And again, it's not a shame game. It's just about being really concrete about a data point that I hope we keep tracking so that Portland Street Response can continue to be utilized more often. Is that fair, Robin?
I think that's fair. And I think it goes back to the comment of knowing what is the percentage of calls that are coming into 911 that are mental health related, right?
Yeah.
Understanding what the problem is so that we can actually develop this program to meet the need wherever that is. So, when we talk about our 3 goals for outcomes, one of them is we had traditionally put just to reduce the call volume to police and fire. But what we discussed, you and I, was maybe we need to revise that. Maybe it really needs to be reducing the number of mental health related calls that are going to police and fire. How do we address that need? And so, I think that's going to be a work in progress, which is why we're in this pilot. It's the whole purpose of the pilot is to assess and determine what that looks like.
Yeah, thank you, Robin. I really appreciated that aha moment I had with all of you. So I wanted to share it today in this work session. Thank you.
Thank you.
So now I'll turn over to Jackie Thompson with Project Respond. Jackie?
Yeah, thank you, Julie. And thank you everyone for having me here. I can't see everybody, so please don't hesitate to just stop me or interrupt, or maybe Julie, if you see somebody, feel free to interrupt me if you have questions as I go through this. So my name is Jackie Thompson. I use she, her, hers pronouns, and I'm here to talk about Project Respond. But Julie is right, I've taken on a new position. So hopefully I'll be in these conversations more and be able to tell you more about the services we do. But today I'm going to really concentrate on Project Respond. Next slide, please. So when asked to do a very brief idea of all of the services that we provide at Project Respond in Cascadia, this is what comes up. So I'm not going to spend a bunch of time on this because it's just a little bit confusing, and I just want to concentrate on the far right side today, which is our mobile crisis response team. But this is kind of showing everything. So location, Gresham, Portland County. What do we provide at Cascadia as far as our crisis service response? We have an urgent walk-in clinic. We have sub-teams of Project Respond that have their own designation of who they serve very specifically. And then farthest to the right, you're going to see our teams that work with police officers, and that's the lovely color coding you're going to see as well. So I apologize if it's any kind of confusing. You guys will have these slides and be able to talk to me more if you have questions, but really it was just supposed to be a big snapshot of the services that we have at Cascadia. Do they work with police officers? Do they not work with police officers? And how does that work together? So we can ask questions at the end of that. So how does Project Respond work? As stated, we get our referrals from 2 different locations. We get our referrals directly from the Multnomah County Crisis Line or directly from BOIC police officers. And what does it look like after those referrals come to us? You can see a snapshot as well of the resources within Cascadia Behavioral Healthcare that we either collaboratively work with, that can also refer to us and we refer to them. Some of those have already been mentioned, so I won't go too in depth because I honestly just much rather answer your questions. But we have a street outreach team. We have a behavioral health that is directly in our shelter systems. We have respite. We have peer integration. We have access and referrals to, of course, Cascadia outpatient services. More community-based, of course, is SUD and recovery. We refer to other mental health providers. We want to be really clear about that. Every one of the teams that I oversee, one of the huge things that we do, especially during COVID, what is open? What's available? What is their wait list like? We do not care if it's going to be just us specifically. We will refer out if somebody else doesn't care which service they go to. Like, no, I just want to get into outpatient services. Great. I can have this wait list. Here's what it looks like for this place. And of course, we do it based on someone's need. If it's location based, we're going to do that. All those kind of things are incorporated into our assessments and when we refer out from those. Emergency departments are definitely on that list. Physical healthcare, shelter programs, safety net services, all those ones that were kind of incorporated in everything that we could refer to in our community. We definitely want to know those resources, and not only know those resources, like what's available, what does their wait list look like? And so that's kind of just the big idea of Project Respond. I want to go to the next slide. These are statistics, and I'll go very briefly into episode versus distinct clients. Episodes is kind of what we describe as the moment in time for somebody when we are engaging with them, not just the initial, hi, what can I do? We try to engage with somebody for at least a week. It's still a crisis response, and we want to be involved and do follow-up care within those 7 days. And so episode can be up to 7 days when we're engaging with folks that we get referred to. And so that I always just say that's the difference in those numbers, is to look at how many episodes, how often are we seeing somebody more than once? And then the distinct clients is taking out, even if they've come back for services, we're still counting them once in these periods of time. 2018, 2019, 2020. We can go to the next slide.
Before you move, could I ask the question, please?
Of course. Of course.
So this is annual data?
This is annual data, yeah.
So there are not a lot of individuals, what you say, that are actually being served through this. I mean, if you think about the people experiencing mental health issues in our community, this is kind of a very small subsection. Would you agree with that, Jackie?
I mean, I guess I'd have to say yes, because we see people that are experiencing mental health issues. But I'll add a tiny bit there that just says we're serving a specific criteria of people in emergency mental health crises. So I would say leading up to that, there's definitely this whole aspect, which is part of our sub-team categories as well, that we want to be proactive and not see people in this deep crisis. State. Yes, yes. But these are those calls, by the way. That's why I said this is a big map of everything we do. This is narrowing down those crisis calls and those episodes of care. But yes, I would say we see the need every day that is not being addressed. Yes.
And one last question before I let you finish your presentation. Just how often are you encountering someone that you have no place to send them or take them?
If you're asking me, sending them and taking them to shelter, the majority of the time. If it is a houseless individual, I'm seeing them and they're telling me their primary concern. And you know, my job is to make sure safety is number one. And yes, housing is part of our safety assessment, but it's not always the forefront, depending on what comes my way. Sometimes it isn't housing. And I know that can be a surprise sometimes when you're not in it all the time, but sometimes I'm simply trying to make sure I can get a weapon away from someone, to be honest, that they were going to use on themselves. So it kind of depends, but I think the big question we get asked, and it's true, what is the limit of resources? It's shelters. Shelters have dramatically increased how many there are, but not their capacity, right? Because they have to mitigate the
physical
distancing,
right?
Yes, the lovely COVID that's been given to us. So I would say housing is absolutely something that we feel so debilitated by. Like, I wish I could do that for you And we try to stay on top of those wait lists, by the way. Like I'm happy to call 211 to see if they can get into Gresham Women's Shelter or something like that. But unfortunately, in my heart, I know the answer is no. And so I try to make sure that we have tents, sleeping bags, all that kind of stuff to say, it's not going to be tonight. Here is something that I can offer you that at least will provide some warmth, and I can give you some ideas, especially if people are really new to the community. That always makes me pretty nervous, of places that I've been told working with people who are houseless that are semi-safe, and places that they don't feel as safe. And I kind of ask the individual specifically, where do you want to be close to? Because I am referring them to services after that, right? Like after tonight, I'm so sorry. And if things get really bad, here's the hospitals that are nearest to you that you could go to. But if you don't want to do that, I understand. Here's a sleeping bag, here's a tent, and here's where I want you to go tomorrow, right? Day services. I need you to go down to TPI. Where can I send a cab to you? Where's a location that you know? Do you think you could get there? Or do you want to do the best? Do you want to have like a day pass to do a couple of things? You know, like it gets really creative and all that kind of stuff. But the limitations are there for immediate response, like especially when someone's in a crisis and new to the community. We see that so often, and so do you all. Where am I going tonight? I'm a single female. Where am I supposed to go? Here's a tent for you. That's hard. That's really hard. So I would say that's a limitation for sure, is homeless resources for immediate, like even a cot for the night, you know? So that is limiting for sure.
Yeah. Commissioner Ryan has a question, Jackie.
Yeah, thank you, Director Myers. And I saw your 1 hour call out, so please rein us in when you need to. I didn't want this slide to move on and without calling out the fascinating asterisks over last fiscal year. I think the eye test and what a lot of us are experiencing is an increase in mental health episodes, and yet COVID is the reason why the numbers are down. That's just such an irony for the public to digest. So could you just give a little bit of narrative to explain the asterisks for those tuned in, including me?
Yeah, I mean, so the asterisks are twofold. So to hit on what you've said, we did have a dip, which we weren't expecting, like all hands on deck, we're ready for these calls. Let's go. What supplies do we need? The county was so great about being proactive in those realms. Like here's tents, here's this stuff, because people are going to want to know what to do. What do we do? Yes, we're sheltering in place. What does that mean? What does that look like? And then it didn't happen. And I think just in our community, we felt that all along. We were like, ready, let's do it. And then it took, like, I think when I looked statistically, about 3 or 4 months, and then the flow did come, and it's just continuing to. And I think that's efforts community-wide to say exactly what you guys are asking. Who do we call?
Yeah.
Where do those calls go? And then they did. So in my mind, these asterisks are twofold, which does represent that. But now we are absolutely seeing almost double.
Yeah, and Jackie, to that point, if the numbers for 2021 in 6 months, individuals, that would be similar to distinct clients, correct?
Yes.
Okay, and so that right now, if you factor that out by 2, that would be higher than the last 3 years at the rate it's going. Okay,
correct.
So it's more culturally responding to COVID in general, just not parallel, but similar in the school systems when we lacked that reporting about domestic and child abuse went down in cases, but we know that the incidents and episodes are probably going up, but we didn't have a system at the beginning of COVID to get that kind of information. So, COVID paralyzed us in so many ways. Okay. Yeah.
Sure does.
And Jackie, I think the mayor had a question for you also.
Yeah, again, Mike, I'm cognizant of the time. This is really interesting. It's important. So sorry, we may just have to have another session here. Jack, I want to thank you first of all for the work you're doing. This is incredible, and I'm grateful to be getting more of an in-depth understanding of the customized help that you're providing in the community. I had 2 quick questions. Maybe they aren't quick, but first of all, thank you for identifying shelter as a gap. Could you tell us, walk me through when somebody if you get to a location and there's an individual and they're clearly in a state of crisis, where do you take them? I assume a hospital. How do you transport them? And what is the likelihood that there will be capacity for them? And if there is no capacity, what then?
Yeah, that has been the last year. So great questions. So what does it look like when I go, and what it looks like if somebody is in a mental health crisis? I mean, I'll go a little bit in depth, but I know we're strapped on time. So we do a complete mental health assessment, which is a mental status exam, is kind of what you guys might hear about is this, and what we're really looking for is a snapshot of somebody's resources, which look different for everybody, and their baseline looks different for everybody. So it's everybody wants this like black and white. When will I take someone to the hospital? When will it match that? It really, truly depends. And it depends on a lot of things. Has somebody been houseless for a long time and knows how to navigate services? That is very different to me than somebody who just got to the community, was not supposed to be homeless. I hear that a lot. I wasn't supposed to be here. This wasn't supposed to happen. I was supposed to have this house with my family member. That fell through. She kicked me out. I have nowhere to go. They're telling me the same things, but I am assessing this female as more acute than this person. And unfortunately, in our community where there's a need higher than the resources, we have to do that. And so it sounds really harsh, but those are what the things I really like to get into. Is there isn't a black and white, because it's based on the individual. If they can maintain, and what I'm really looking for, can someone care for themselves and it's not a danger to themselves or somebody else within a short period of time, right? So even if I'm assessing somebody's suicide and they have everything we worry about, plan, intent, means, but their timeline is a week off, I'm still don't have what I need to require them to go to the hospital. We can talk about that all day long. To get back into your questions, what it looks like is I go out, and what you're saying basically is somebody's meeting my assessment criteria. They are unable to safety plan with me, resources are unaware, or maybe they are just incapable of communicating that, which can be part of my assessment, right? Like I'm assessing for everything that I'm seeing that somebody is potentially hurt, is unaware that they're hurt. I'm assessing, are they aware of their surroundings? Did we talk about orientation? Do they know where they are? If all those things aren't happening as well, that's part of my assessment that says this person needs to be monitored. So what gets confusing is I have gone through trainings, and everybody at Project Respond has, that says this person meets this criteria for director's custody hold, which says it's a transportation hold. So that gets a little confusing too, because then I can only say this person needs to be seen by a physician at a hospital and needs to be transported to do that. At the hospital level, they have their own criteria that's even higher to make them stay. And that's going into the 24-hour holds, all that kind of stuff. So I assess someone, transportation is done by AMR. And that used to be different. And now, I mean, just a lot of stuff has happened for AMR and assaults and multiple things, and I won't talk for them, but this is how it works. I say hold criteria has been met. I do everything in my power to try and just have the person understand why I'm so concerned, why family members are concerned, and why I think they need to go to the hospital, and try to have them collaboratively work with me on that. And sometimes that doesn't happen. That means we are making the person go because they have met such a high bar that says within the next 12 hours, I'm worried about this person dying in one way by their own hand, or getting hit by a car because they're not aware of traffic being very close to them. Multiple things can go into that assessment. So when that happens, it is this collaborative approach that AMR will come for transportation. And sometimes I will have to bring police officers in, because currently how it stands, the only people that are going to put hands on are police officers and AMR, but AMR will not touch the participant until they are on the gurney. And that's new safety protocols that has happened. So truly I can have about 20 feet where I'm not putting hands on, but a police officer has to come in and put the person on the gurney, and then they get to the hospital.
Wait, Excuse
ahead.
me, Jackie, I'm sorry to interrupt. You just said a
No,
new
please do.
protocol with AMR is that they don't touch the patient until they're on the gurney.
Correct. And these are safety concerns that have happened because there's been so many assaults on AMR.
So what does that mean? That we're going to put fire personnel in more danger rather than AMR, who actually has a contract? That's problematic for me. I had not heard that.
Yeah. Yeah. And that was newer to us too, right? As we continue to try and decrease police involvement until it's needed, right? We're assessing things very much that way.
Who do they expect to put patients on the gurney if they are the ambulance provider? Who do they expect to put the patient on the gurney? The police and fire?
Police and fire.
That's not acceptable. How do you change rules and not tell us?
I'm not sure. And I'm sorry
know.
if this is
I'm sidetracking, but that just,
no,
I
you're
had
fine.
not heard that. And I find that very problematic when AMR changes rules that has a huge impact on police and fire without having a conversation with us. So,
Commissioner, we'll look into that for you and get something back so we understand it a little better.
Appreciate that. Thank you.
Of course. Mayor, if you don't have any other questions, we'll let Jackie.
I just want to say thank you for those responses. I appreciate it. And I don't get a chance to say this often enough. The work you do is fantastic. I know it's taxing personally for you and your team, but it is so appreciated and so needed. And so I'm grateful that I have this opportunity to thank you personally for it.
Thank you. Yeah. And I'll just add your last question of like, where do people go? And you guys, I'm sure, have heard about hospitals being on divert, Unity being on divert most days. I mean, that's the reality of what's missing, right? We don't have enough resources for the people experiencing mental health crisis. And that Julie spoke to it, right? It goes all the way up to state hospital and that trickles down. And so we are overloaded. So sometimes, I mean, AMR knows immediately who's on divert and they're telling me, and then I follow up with the social worker wherever they're going. But it does look different on the day. It depends. We have, the hospitals that we want, and we talked to the person about that. Have you ever had a good experience? What did that look like there? I can try, but I can't promise because they might be on divert. And it would be great if we had more capability to send somebody where they wanted.
Director Myers hinted at that right at the beginning. So we'll figure out what our local gaps are here, and then we will work with a sense of insistence with our partners up the food chain to make sure that the resources we need to make our resources work are also in place. So thank you for that.
Yeah, thank you.
Just a reminder, we're at 10:45 and we've got 45 minutes left. Two others still need to hear from Police Bureau as well as the Beacon Project. So just a time check. So maybe we can be brief on these next two, although I think the second one, Jackie's pretty important, but.
Yeah. And I will buzz through these because absolutely reach out, I'm happy to talk about this all day long. So these are the outcomes. And yes, we absolutely do get into this realm where you're people in the community, and we really are trying to say, we don't always have to bring police. We don't. There's assessments, and yes, we go out on crisis calls, and yes, we go out when there's weapons involved. So yes, you will see us more than other community providers bring police officers for these very big reasons. But we really want to highlight what is the outcome of most of the calls we go on. Yes, we do director's custody holds, and we're a community provider that's highlighted for that, right? Like, this is an emergency response. We need this person to come out because we're worried about this person dying. We're coming out and we're saying that is potential. This person needs to be monitored. But it's not the majority of our calls. And we just really want to highlight that. The majority of the time we are going out, engaging with community members and seeing what resources they need and connecting them to those resources. So that's what we're saying when it's a community plan. That is a big category that describes everything else besides going into the hospital system, subacute system, and jail. Everything else, staying out in the community, doing community partnerships with multiple other organizations. Then we fast forward to, we have two teams that directly are embedded in the police system. We have a team with Portland Police, and we have a team in Gresham. And these are what we call co-responding teams. And so, yes, they're part of Project Respond, but they're different. They have a clinician and a police officer on a team together, and they go out embedded in the police system to these calls where people are high utilizers using emergency services such as 911 for things that maybe 911 isn't the most appropriate for. So these teams go out and engage with communities as a co-team. When is co-response needed? They do absolutely go on calls where safety is a concern and people do have weapons, and it's been an incredible collaborative relationship there because police officers have really a lot of resources to help with, gun locks, all those kind of things that we were like, wait, mind blown, we can de-escalate and remove means all at the same time. Usually we'd have to kind of piece that stuff together. So there's many different ways like that. Yes, co-response is needed sometimes for director's custody holds, absolutely, because we do not put hands on. And sometimes when people need to go to the hospital and aren't willing to go, we need to have them go. That looks a little different. And then, of course, I always forget this, so it's so good it's put on here, medical needs. We will show up and someone is unable to assess how they're feeling, what's going on, and I'm seeing something happen. Like I've seen someone who's like, look broken. Do you feel your leg? It looks completely bruised. What happened here? Really unable to do that. I am calling AMR out to also just clear someone medically. I'm not a medical professional. I'm also doing those co-responses to actually just see if somebody needs to go to the hospital medically. We kind of forget about that in the mental health realm. So fast and furious right there.
Thank you so much, Jackie. And finally, I'm going to turn to Casey Hetman from the Portland Police Bureau. And Casey, you have a number of slides. Just going to do the quick reminder of time, but we'll turn to you.
Yes, indeed. Thanks, everybody. My name is Casey Hetman. I'm a lieutenant with the Portland Police Bureau. I currently oversee the behavioral health unit, and I've been in that capacity for several years now. Excited to be here, and I know that you guys had some interest in the data and the stats. I've put some of those numbers in the chat for you all. I just want to highlight today our scaled crisis response model that the Portland Police Bureau engages in partnership with our community-based partners and our partners with the county. And to do that, I like to cover the training that both all of our officers in Portland have, and then also our enhanced crisis intervention team officers receive as well. So I think, Julia, if you push next, I think there we go. So all sworn Portland police members do receive 40 hours of crisis intervention training. And we've kind of bucketed that training here on the screen. A lot of that curriculum centers around signs and symptoms of mental illness, communication skills. We have consumer panels where we hear from individuals that are living with mental illness and what those experiences are like for them and how they interact with law enforcement. We also highlight a lot of de-escalation strategies and tactics. We cover bias and stigma awareness as it pertains to mental illness and mental health. And we also culminate all of that training in scenario-based training where the participants are evaluated on their understanding of the core competencies and concepts. We do augment that with our enhanced crisis intervention team. We have about 140 officers that are operational with that additional training. They are volunteer officers that are heavily vetted, and it is for no additional compensation. So these are truly people that are volunteering for this additional work because they have a passion for the work and are really there to better serve individuals within the community. And that curriculum goes into more depth as far as the topics covered in the basic 40 hours that everyone receives. When we build upon that, we have a course of instruction from our crisis negotiation team and crisis communications. We go further into local resources and so that they have more of an expanded knowledge base on that. We also provide additional panels from consumers once again, but then also family and loved ones. We partner with NAMI and work through that as far as how we can better interact with persons experiencing crisis, but then also their loved ones and support people in their lives as well, to how best support them and get them connected. We also do more advanced scenario-based training where we also do more evaluation as well to ensure that we're getting the right product and that the training is effective. And then lastly, we also do site visits to a number of mental health residential facilities within Portland where we actually take the students to those locations to both meet with staff and some of the residents there to build those relationships and better understand partnering with them. Next slide. So I mentioned talking about this response model and more of a scaled system and trying to get the right responders to the right crisis and not overutilizing one responder versus another and have it be more scaled and appropriate based on the circumstances. And where that starts is with BOEC, and we've touched on that slightly already, but we partner with them to help provide crisis intervention training for their call takers so that they can better assess and triage calls as they come in and identify calls that, for instance, can be warm transferred over to the county call center and avoid a police or fire response altogether. We've seen value in that. We've been doing that now for several years, and we are able to successfully divert a number of calls away from other emergency services to the county call center for a more appropriate response. And an example of a call that might go that route would be somebody that's maybe having suicidal ideation, but they don't have a weapon readily available, or they don't have a method or a means readily apparent to them. So they can be transferred to the call center for resources there. Next slide. The next rung up our ladder is our patrol officers. As I mentioned, all Portland police officers have 40 hours of CIT training, which is a deviation from most agencies throughout the country. We are unique in the sense that most officers throughout the country do not have that level of training. So we are privileged to have that. So we also train our officers to consult with those enhanced CIT officers if the situation is such that they feel like they need additional support or resources at the scene to better navigate a call. We also train all of our patrol officers in Portland to utilize the county's call center. They know how to adeptly navigate that if they are with somebody that could use some assistance, and we know how to navigate finding who maybe a care provider is that someone's already connected with, things that might trigger folks, or maybe some ways to better connect with folks to bring about a safe resolution. So that is an asset that we have for all of our officers. I note on here that we have 24/7 access to mental health clinicians. That's the Project Respond partnership that we have with Cascadia Behavioral Health. And I like to highlight that we've had that partnership since 1993. So we've been working hand in hand with them for over 28 years now, doing those connective work. We also produce a mental health resource guide that all officers have access to, and then they do have an ability to refer individuals to the behavioral health unit should the need warrant, if somebody has more of a chronic case where they need more robust assistance in getting connected. Next slide. Again, this is our ECIT, our Enhanced Crisis Intervention Team. They receive those 40 hours of additional training on top of the other 40 hours. So they have at least 80 hours or more of specialized crisis training, where we have that expanded resource knowledge. They have more of an ability to do situational risk assessments. They're more adept at crisis communication, and then they have a better sense of the resources for those more complex calls. And as I touched on previously, they are volunteer and heavily vetted. Next. We previously in this call alluded to co-responder teams where we're partnering police officers with mental health clinicians, and we do that within the behavioral health unit. We currently have 3 full-time teams, and that is one of our uniformed police officers partnered with a mental health clinician from Cascadia's Project Respond. We currently have staffing to allow for 1 team per police precinct. We have 3 police precincts within the city, and they get their work through referrals from patrol or other areas within the police bureau. On average, we're seeing about 1,000 referrals to our unit per year. And of those, about 50% of those are triaged out and assigned to one of our teams for follow-up. The mission or goal of our team is really to reduce the risk and frequency of contacts with police. and get folks better connected to community-based resources, and ideally prevent future police contacts in the future. Next. So how we do that is we collaborate very intensively with Cascadia and Project Respond. We convene a weekly meeting on Wednesdays where we staff all of our caseload and ensure that we're making those inroads to those service connections and they're sticking when we do make them, make sure that they're effective. So it's been a great partnership and we're lucky to have it. Next. We also coordinate a bi-weekly meeting every other Thursday where we have a number of partners throughout the community in the mental health spectrum within Portland come to the table, and we will staff individuals that are touching a number of different services or systems kind of simultaneously. Often maybe 2 or 3 individuals will be staffed that week, and we really try to find efficiencies and pull out all the stops to ensure that we're getting folks that maybe with the highest acuity are getting the most robust services in the most efficient and most helpful way. So as you'll see around the circle here, there's a number of people at the table to include social services, the sheriff's office, involuntary commitment program from the county, mental health court, parole and probation, and then a number of the community-based mental health providers as well. We find that meeting to be extremely effective and very helpful. Next. And I do like to highlight what we kind of have 2 sides of the behavioral health unit. We have the mental health side and then the addiction side of the house. And the service coordination team is a program that provides housing and wraparound services for individuals that are struggling with drug or alcohol abuse and addiction that are also concurrently having a number of interactions with the the criminal justice system. So these folks were breaking very, very entrenched patterns of interactions with the criminal justice system, sometimes dating 10, 15, 20 years. And we're finding that the crimes that they're committing are fueled by their addictions. And so we bring them into low barrier housing, provide them service, treatment, and wraparound services to ideally break that addiction cycle, then in turn break their interactions with the criminal justice system. Portland State University audits it yearly, and historically have found that for every dollar spent in the programming, we're seeing a $13 savings in criminal justice costs as a result.
Excuse me, Lieutenant, isn't this a Central City Concern program?
So it's a Portland Police Bureau program under the Behavioral Health Unit. We do have a contract with Central City Concern for the housing and the programming and wraparound services, but we do manage that contract.
Yeah, we've had this conversation for a few years, and yeah, I think you have 2 staff that work. You have a social worker and a sworn officer that actually are part of the program. It's just important that people know Central City Concern is the one that actually provides the treatment, the housing, and all the wraparound support services through that contract. Thank you. I just wanted to clarify that.
No worries. Thank you. Next. Oh, and I think that's it. If anyone has any questions, I can feel free to answer any.
So I'm going to hit these next couple slides super quick just to let you know what we're working on. And Mayor Wheeler, you have a question? And then
yeah, just well, maybe it's not quick, so I won't preface it. Lieutenant, thank you for that presentation, and thanks for your great work as well. How is this program coordinated with the others that we're hearing about today? The training that you've suggested is invaluable. The types of services you've offered are really important. Some of them sound similar to the types of outreach and service provision that we just heard from Project Respond. How are we coordinating? How do we decide which of these organizations, which of these partnerships actually is deployed? How does that coordination take place?
So the work that BHU does is really coming from the referrals that I mentioned that are coming from patrol or other areas within the police bureau. So in a lot of ways, the folks that we're serving are folks that are already having police encounters or police interactions, but we do heavily partner behind the scenes with both a number of county programs, as well as the new street response. We meet bi-weekly behind the scenes. I meet with Robin and her team to coordinate what these overlaps look like. And we meet bi-weekly or monthly as well with a number of other county programs as well, just to find the right spots where how we best insert ourselves. And it's really that Thursday meeting that happens every 2 weeks where a number of those teams are all at the table, and we're finding those people that are kind of being touched by all of those different areas that we'd really try to hone in on.
Thank you.
All right, so I'm going to just hit these things really quickly because honestly, each of these three things could be complete presentations in and of themselves. But I'm just going to want you to know what we're also dealing with that is coming that we need to navigate and collaborate on, or else it could be messy. The first of these has to do with the new 988 line that is coming. This is a federal initiative that is considered to be the behavioral health 911. I'll just say this was locally, this was folded into House Bill 2417, which was Representative Sanchez's mobile crisis bill. It will include hotline and is supposed to coordinate with our mobile crisis and crisis stabilization centers. We're working diligently with the state and with Lines for Life to see what we can do to minimize any disruption and overlap or duplicity, because that's been our concern since the beginning. I think it's a great idea because on the one hand, it'll be an easy number to market and for the public to remember. On the other hand, it could get messy if we are not super intentional. So we are working on that. And Commissioner Hardesty, I see you're shaking your head. I'm with you on it. Also, of course, we have the new funds coming through Measure 110. And this hopefully will expand outreach. And what we're really hoping is not just expanding what we already have, but filling the gaps in culturally specific spaces and geographic spaces so that we are not just doing more of the same, but doing better with the resources that we're coming and being involved in that intentionally. And then some of you have heard, hopefully, that we'll be opening late summer, early fall, a Behavioral Health Resource Center at 333 Southwest Park downtown, which is 4 stories that will include a day center, completely peer staffed, for up to about 150 people. That'll include lockers, outdoor space. They can bring their pets. They can bring their whatever they want. That'll include access to medical care, showers, kitchens, all the things. The 3rd floor will be a short-term shelter for those who are interested and ready for that. And the 4th floor will be what we call bridge to housing, which will help those folks move into longer-term permanent supportive housing. Again, I could spend days on this, but all these things are coming, and we are working on the what next and how the behavioral health resource ties into this overall connection. It's that thing that it works to prevent crisis, help people access the things that they need. And all of this work absolutely depends on us collaborating and not competing, which leads me to our next presenters, which is going to be Aaron Loans and his team of Behavioral Health Emergency Coordinating Network, because I think they've done an excellent job saying, how do we do this better? How do we collaborate? And they've been very intentional in working with county, city, lots of providers to develop an idea and a pathway. So on that note, I'm quickly going to shift it over to Aaron Loans. So I will stop my.
Thanks, Julie. This is Aaron Loans. I'm the project manager for Behavioral Health Emergency Coordination Network. And I'm going to share my screen here and kick it off by passing the ball over to Bob Day, who's going to get us going. Bob?
Hi, good morning, everyone. Mayor, commissioners, thanks for the time. Thanks for everybody's efforts this morning in the presentation. I retired 2019 as a deputy chief, with the police bureau, and was grateful enough to have Mayor Wheeler bring me on in 2020 to try and help find some solutions to the closing of the Sobering Center, which led to a large collaborative effort towards the end of 2020 with just a great group of people that we're going to identify here through this program, and some that you have heard from today. And the city and Care Oregon joined forces to fund Aaron's position and really taking this opportunity to a new level. I want to start real quickly with just a personal story. I remember in 1990 very clearly as a brand new police officer with my coach working down in the Old Town area, coming upon a man late in the evening. It was early winter, cold, wet night, huddled in a bus shelter near about 6th and Pine. I can see this so clearly in my mind. And as we got out to talk to him, he was clearly intoxicated, wet, shivering, had vomited on himself. And my coach asked me to assist him in getting into the car so we could take him to sobering. And this was back before we wore gloves or knew about some of these other precautions. And as a kid growing up in the suburbs with a lot of opportunity and access and privilege, I didn't want to take the time to touch him and help him. And so I asked him to stand up, of which he promptly fell over. Fortunately, did not injure himself. My coach quickly interceded, picked this man up, helped him get into the car, and we drove him over to sobering. And as I walked in and met the people working and helping this man, and after a very direct conversation with my coach, was just reminded of the humanity in everybody and the value in everybody. And it was a great, powerful lesson for me to learn early on about the need to be proximate, to be willing to step in, to actually touch and connect with folks, which many people on this call are doing on a regular basis. But it's the reminder of that incident that has really compelled me, even in retirement, to continue to stay connected, to look for opportunities for many of these folks that are being left in the gaps of these systems that we've created. So hopefully, as we come through this presentation today around the effort at Beacon, you'll see the coordinating attempt to try and really bring together many of the programs that have been spoken of in a more efficient model to reach some of these harder outlying and folks that have been left out. So you're going to hear the scope and model of the program. You're going to hear a brief timeline. You're going to hear a lot about our collaboration and key takeaways, which Julia just mentioned, I think is key. And then we'll finish up with a quick what's needed slide with the time for some questions. So I'll turn this over now to our next presenter, which, go ahead.
Monica, yeah.
Hi, everyone. Good morning. My name is Monica Parra, and I'm the Community Engagement Project Coordinator for Beacon. A large part of my role on this project is to facilitate interviews with people with lived experience in the crisis and criminal justice systems. And I'd like to start off with this presentation by sharing a story from a recent interview to really help ground us and remind us of why this work is so needed in our region, in our city, and so important. I know it's been a long one, and so please be mindful and take a moment to stretch if you need, so we can finish this off really strongly. So in the slide shown, you'll notice that this consultant is a family member whose loved one is struggling with addiction. And I've listed the questions from the interview as well as themes that I found. This consultant self-identifies as a Mexican Hispanic woman and mother whose primary language is Spanish. She shared with me that her daughter has been struggling with meth addiction, and there's days where her daughter will literally run out of their home and will leave for a day or a week or more at a time. And she has zero clue on where she goes, who she's with, and if she's even leaving voluntarily or if she's being forced to. When eventually her daughter does return, she sleeps for days at a time, and all she feels she could do for her is make sure she's still breathing. She's tried calling everyone, every crisis line, the police, DHS, over and over and over again. And everyone gives her another number to call, someone else to have to retell her story and relive her trauma. And, you know, they don't ask many questions. She's frustrated and exhausted that no one understands. There's not enough compassion, and she can't even simply find someone to help translate. Because Spanish is her primary language, she's not able to fully express and have someone listen to what she and her daughter need support in. And this mother is just terrified on a daily basis, moment to moment basis for her daughter's life, and struggles with her own mental health. She feels suicidal at times, she shared with me, and just so helpless. And our community is suffering, and we need culturally, linguistically responsive services, and we need to implement a trauma-informed lens in every single aspect of crisis services and care. So with all that in mind, I'll pass it over to Erin. Thank you for listening.
Thank you, Monica, for that. I'm going to give a quick kind of espresso version of what the Behavioral Health Emergency Coordination Network is. And I appreciate Monica's grounding and why we're doing this. So basically what we're looking to do with this, we've been working, as Bob said, for about 8 months to create a front door and networked approach to the Multnomah County Portland Metro Crisis System. There are some fundamental tenets that we're focused on as we develop this. One is, as Monica talked about, this culturally responsive services and in-reach, really finding some new and innovative ways of weaving in peer provider support at first encounter and through the process, having a continuous quality improvement process that prioritizes customer and community voice, kind of like what you heard from Monica, woven into everything that we do. Doing a great job of coordinating with the Multnomah County Local Mental Health Authority, as Julie was talking about, as well as the mental health programs that are out there, and really designing the model to meet the sort of evolving OHA Crisis Receiving Center and Measure 110 design criteria. And if you haven't heard about those programs, those federal level programs and what's happening at the state, I know there will be more, and I'm sure Julie can give you more information on that. So bottom line, Beacon is about people getting the help they need as early as possible in the safest and most supportive setting as possible. And the way that we see this working is having a single facility to basically replace sobering, but there's going to be a lot more thought that goes into this and ability to meet the needs of the community. And so low barrier 24/7 access to first responders. So Portland Street Response would be an example of that. And the community provider referrals. So if there's a referral in, we can accept that. Pre-arrest and pretrial diversion programs. What we're not going to do is start this thing off. We're looking at a 2022 launch. We're not going to start this thing off and open all doors and not have it be really focused. We need to be very scoped and very focused when we start and learn. And I'll talk about that in the next slide. On-site services, we need the ability to screen, intake, triage, and have, again, that peer provider engagement from first encounter. This is really the unifying and probably one of the biggest value propositions for what we're trying to do here is the ability to coordinate all of these efforts that you've heard about this morning. Development, we would develop out a crisis stabilization capability along with mental health support services, and then have innovative and new ways of approaching sobering, not just for alcohol, but also for meth and opiates. And as our design work groups have developed this model out, it's really clear that we need to think broadly and creatively outside of the box about how we approach meth. There's just a lot to learn there, and that's part of what this next phase that we're going into will be really focused on. And so once we've got someone stabilized, triaged, and they've been assigned a peer provider, we understand the underlying conditions. We've helped to get them, again, sobered. We are going to coordinate that access. So again, back to that network. So if they need to step up to the PES, the Psychiatric Emergency Services at Unity, they need to step sideways, maybe to urgent walk-in, Behavioral Health Resource Center that Julie mentioned, or any number of other services, including housing, job skills, and what have you. That's what this network is meant to do. And so when we think about timeline, we look at the Beacon approach, phase 2. We just started phase 2 basically in August. We've done 8 months of sort of planning. We have a design that I just showed you, high level, again, sketching the house. We haven't done the blueprints yet, but we sketched the house going into this fall in 2022. It's about establishing that program foundation, developing that model, really clarifying the facility requirements, identifying that facility. We certainly have some facilities in mind, but really confirming that and beginning to develop that facility. And then going into 2022, probably the end of 2022, a commitment to a Beacon soft launch. This would be very tight, small, bite-sized pilot. We don't want to overcommit and underdeliver. Once we've got that going, expanding the model, refining, expanding as we go, learning from things, identifying gaps. And you can see that bottom right-hand box on where some of those gaps might be. So, do we want to look at other geographies for a facility if we replicate this facility? Do we want to look at other types of services that we can integrate into the model? And how do we think about, really continuing to integrate that network partner services that are already existent? Once we've got those gaps identified and we've got a path forward, that's when we hard launch this project to really stabilize and grow. With that, I'm going to pass it off to Jill Archer that's going to talk a little bit about our collaboration. Jill?
Hi. Yeah. Well, thank you. In the interest of time, I actually thought it might be best to hand it off to Bob for our closing slide, knowing that we only have 10 minutes and looks like the mayor would like some time at the end. Hopefully everyone has this PowerPoint and can look at just the volume of organizations that continue to show up and participate, and really the collaboration that's happening on a daily basis with this project.
Bob?
Okay, so a couple things. There's always an ask, and we are looking at really coordinating a ongoing high-level governance model that includes obviously the Multnomah County and their the Mental Health Authority facilitates, supports alignment, all the things that go with that. Of course, the City of Portland, criminal justice system, the CCOs are all going to be factors in this as we talk about funding. The reality is, as we enter into phase 2 and really begin to formulate the blueprint, as Aaron had mentioned, it's going to require additional funding to support this project. And then, of course, there'll be the ongoing and the capital outlay down the road. But this is really an opportunity for us to inform you folks. We're looking forward to working with the mayor and the chair's office and really coming back with a concrete financial ask in the very near future. I think at Lipsick yesterday, Commissioner Hardesty summed it up well. There's a sense of urgency here and to reach these folks, and I look forward to being able to bring back some numbers and ideas about how you can weigh in and help. So thank you for that. Mayor?
Well, thank you all. I appreciate it. We still have a few minutes here. And so I want to make sure that we have time for people to ask any questions that they have, or Mike, if you want to wrap it up.
Yeah, I'll take it from here, Mayor. I think, we had a host of questions. Obviously, this is such an important issue. We ran long, not unexpected. I think we do, Mayor, need some follow-up, if not another work session. So
I'm hearing, and if I can just get a head nod from my colleagues, I think we agree to that. I think we need to take it from here. We've heard some great presentations, and Bob, thank you for the Beacon presentation, for meeting with me earlier. And I think you've reached out to my colleagues. I mean, this is a great opportunity. The question we now have, Mike, is Director Myers, sorry, I shouldn't be presumptuous, is how, all of these as standalone programs are absolutely necessary. And the question that I think you've heard over and over is, how are these services integrated? Where are the gaps? What is our role and responsibility as a city council? And where should we land in terms of supporting these here, or supporting our county partners or our state partners or whoever? What is the right balance for us? How do we thread this needle? How do we be a collaborative and effective partner to the county and to others who are providing these services?
So, Mayor, I'm prepared. Go ahead.
No, go ahead. That's enough of me.
So I'm prepared to put forward a policy paper of some recommendations on things I think we should do. And I'm sure it will create some dialogue between council staff, yourself, Mayor, and then our county partners. The goal is to have a strong partnership, but we need to move on a few things. And clearly, we're not going to get out of this situation without some heavy investment. Julie, did you want to comment real quick? I know you have your hand up. I don't want to. You've done such a great job today, and I can't thank you enough for being here and helping us.
Well, and I think, to be clear, I think we have worked for a long time to create an integrated system. So Project Respond, the call center, and Portland Police have very well integrated programs. Portland Street Response is new-ish to the game, right? So we're working on that, on continuing to expand and improve that overlap and coordination so that we can truly have a seamless crisis response system in the mobile crisis space. I think we heard some clear things too about how do we better collaborate, across with including fire in this continuum as well. So there are some things that are happening really well at the program level. It's really, I think, part of the partnership and collaboration. And my teams meet with EMS, with AMR, with all of the crisis teams. We meet with law enforcement on a regular basis. I think it's at this level here where we need to be more intentional and how do we partner across city and county and make sure that we are working in together as opposed to one of us shooting off and saying, oh, well, we'll fix it here. And then it disrupts something else there. And we really need to be intentional. That would be my hope.
Yeah, thank you for that, Julie. I think I've seen a lot of head nods, and I think we're all in agreement that that is the primary goal for us to be collaborative, intentional, and we share this system here. So, Commissioner Hardesty.
Thank you, Mike. I just wanted to appreciate Judge Nan Waller, who's been on the call with us today. This is her baby, and she's been working on this baby for a lot of years. And I just wanted to acknowledge and appreciate both her hard work and her being part of this work session today.
Yeah, the judge always present. Judge, I don't know if you want to say a couple of comments, but we're so appreciative of the work that you do.
Thank you, Commissioner Hardesty. And my view from the bench is one that gives me both the unique perspective of what's happening on the ground level in terms of some of how these things play out, and then how the policies, and often very well-intentioned policies for the population I deal with, it's a forensic population, people who are involved in the criminal justice system. And for that population, we absolutely need more open doors. And so it's part of what's driven me to working on Beacon, is because I often am left literally with people walking into my courtroom saying, please take me to jail. I don't have any other place to go, Judge. That is not how we want to use nor can we use our jail resource in that way. But that should never be the only option available for somebody who declares that they are in every kind of a crisis, physical, mental, emotional. We need other options. And so I see this was a wonderful opportunity for me today. I just was absorbing all the information so that because it's incredible to have it all in one place. So thank you all for letting me listen in on a wonderful presentation.
So Mayor and Council, if it is in your interest, I propose that I be allowed to put together a policy paper. I'll work closely with Julie Dodge and county leadership to make sure this is a shared policy paper. Come back to you with some recommendations. I can meet with you independently. We can work through this together. I think the biggest point is we have a lot of work to do in front of us. Nothing here sounded easy. A lot of it sounded messy, but we can get through this. We need to be, I think we agree we need to be aggressive. This is a crisis. If that is something this team is interested in, I can do that lift. We can leave it at that. We've got just like 3 minutes left. Mary, you can close us out. I can answer questions, or we can also have another session to continue this conversation with less presentations and more discussion.
Yeah, you don't need to hear more from me. If there's questions, let's get to those.
And if there aren't any, I'll take that as a positive to go forward with what I recommended.
Yeah, hey, good. I think you're seeing thumbs up, head shakes all around. We'll give everybody 2 minutes back. Thank you, everyone who participated today. This was just a fantastic and much needed work session. And I know I speak for all of us when I say the work you are doing, it is God's work. There's just no question about it. This is humanitarian work. This is working with the most vulnerable people in our community. This is trying to help people reconnect with loved ones and people who care, and help them at just the darkest time of their life. And I know it can be exhausting. And I know there's a lot of stress and a lot of burnout, both maybe for you personally, as well as your teams out there in the field. All I can say is I cannot respect you enough. So thank you for being here and sharing. We want to partner with you. We want to help you be successful in your important mission. And that's what we're going to do. So Director Myers, I'll give you the last word.
I put the last word in the comments. Thank you, everybody. Great job. I think we have a lot of work to do together. So let's stay together. Let's stay collaborating and understanding. It's going to be difficult. And I appreciate everybody's time today. Please have a pleasant rest of your week. And thank you for the hard work.
We're adjourned. Thank you.
Recording stop.